Assalamu alaikum, Doctor. Do you start, guys? So, hi, Dr. Prof. Rashid Al-Abri. We're just waiting now for some participants to join. So we'll wait like an extra 2 minutes until it's 5:05, and then maybe we can start. Yes, of course, Doctor, you can go on. Do you know what the problem is, Dr. Rashid?
Just Mayan, if you can give him the co-host.
Yeah, I did.
All right, okay, thank you.
Now is okay, thank you. Initially I was not given the host, so thank you for that. Can you hear me well? Okay, good.
Yes, Doctor, we can hear you. You're very audible.
Thank you.
So I'll be sending the slides that I prepared just now. Then
Thank you.
maybe for the other half, you can finish.
Okay, inshallah. Or we can continue with the same background, inshallah.
Okay, yeah. No problem. So give me a second. Okay, now that we have an addict number, I think we can start off. So I think, thank you to each and every one of you for being here with us today. We are very, very pleased to be able to welcome those of you that have been with us for a long time now in the NGA. Maybe it's not your first NGA. And for all of those that are attending for the first time. Before we get started, we would like to extend a special welcome to our key presenter for today, Professor Rashid Al-Abri, an MD FRCS. He's a professor and senior consultant in ENT and also the head of medical education and informatics department at College of Medicine and Health Sciences at Sultan Qaboos University. He's also the director of WHO Collaborating Center for Quality and Patient Safety Training at the Ministry of Health. In addition, I would like to express my sincere appreciation to all my team that generously helped us make this event come together in this short time. So welcome all to Prof. Rashid for being able to present with us today and my team also. Thank you, Mayan, for pinning him. Now, as medical students that engage more with the medical field day after day, we continue to raise questions related to our future medical profession. One of the topics that continues to be raised in our society and between medical students is medical errors. So we chose it to be our theme for this year's NGA. Within the next days, we hope to aid you with all the information that will answer the continuous raised questions and more. At the end, I hope that today inspires ideas and discussions around the way that we can become better future doctors. Now I'll move the mic to Prof. Rashid so he can start his presentation. A special welcome again. Did you receive the slides, Doctor?
Yes, but unfortunately, they're not complete. So what I'll do is I'll just show you whatever I have now. And I give you my apology, not able to make it in your background. So first of all, I would like to thank you all for attending, and Lubna for the organization and the hard work you have done. I'm happy to see you around. Some faces I have seen you around in the school here. But really, I'm glad to be with you today to discuss this important topics, which is the medical errors, which as we all aware, we are human, but sometimes the human are humans. So the errors may happen because of the nature of the humans. Sorry for the color of the slide. It's supposed to be in your background, but unfortunately, seems to be I didn't able to make it yet.
It's fine. The content is more important, so it's fine.
Thank you. That's most important. Thank you for your understanding. I'm going to go around today is because the most important for you as a medical students and as future doctors and that to know how to investigate a medical misconduct and which is an error. Not only the definition, it's sort of the introduction, and that will give you a sort of the information about the medical error, how we go around it. As I said, the lecture outline is I'll give a general introduction, and then I'll go to next points like how common is error, why does error happen, how should we think of error, how should we respond to it also, and what do we mean by root cause analysis for an error. And finally, we'll draw some conclusions at the end of today. And I hope after that, this may bring some questions from your side and bring more of the queries, and I'll be happy to answer it accordingly. The objective is to understand the nature of error and how healthcare providers can learn from these errors to improve patient safety, because your customer is patients. Because you are health providers, the main customer of yours is the patients. Without the patients, sometimes our salary will not be there. So the patients in the institution are there all customers. So it should be all oriented to our patient. If you can see this slide is the human limitation and capabilities, which can be separated into human limitation and human capabilities into perception causes and cognitive causes and physical causes. In the human limitation, you may sometimes have differentiation of colors, shapes, and words. That's perception. One of the limitation. For cognitive limitation of human limitation, like short and long-term memory, all of us cannot remember what we studied in the last few years. Sometimes we are only remember short-term memory. You will be able to remember what happened yesterday and day before yesterday in more details, maybe barely for long-term what happened last year. So that shared short and long-term memory will affect our own work as a human. Also the physical stress, time limitations, and also the which is some sort of limitation for everybody, either task limitations or other sort of limitation. So this human limitation, I'm going to explain shortly to you in the next few slides. Human capabilities also we can divide into perception and cognitive and physical. In perception, ability to differentiate and identify different like visual signals, red, black, and so on. Cognitive ability to understand complex relation and make diagnosis, because you can put in the history but the symptoms and signs from physical examination. That's sort of cognitive, and try to formulate a plan. And that's what cognitive should be also working every time. Under stress, sometimes this sort of the cognitive may be affected because you're not be able to gather the enough information, or you're not able to get the right signs or take a decision because of that sort of the stress, and that may lead to an error. Physical ability to learn complex motor tasks such as phoning and driving, texting messages and driving. So that's two things. Is some people have ability to do it at the same time, but with caution. Accident may happen at any time. So that sort of the capability of doing two things together is not always there for all of us in medical field. You cannot operate and you can also watch a football team. I know sometimes you would like to watch your favorite team while you're operating, but not always. This is not the right place to watch the team in the operation theater. but you can do it in between the cases. So that sort of the human limitation and capabilities, I'm going to sum it up here in the coming 3 slides, at least as an introduction for you. Is not enough information is available to the operator to make decision. That's one of the limitation. Also, too much information, the opposite way. Too much information is presented to the user, and some of it is irrelevant to the task and at hand. That may lead to an error also. Information is difficult to find. It's been maybe available in the one of the file which are hidden far away is not given to you, or the person who is supposed to give you the information is not available in the area, and you are going to judge what's going on there, especially in the at the time of emergency, in the road traffic accident or the other things which you need to take a decision, but there's no information provided to you and difficult to find at that time, or information is not presented in effective format to you, where you can take a right judgment and do a right procedure. Information is not in a format that makes apparent how to influence the operator's decision. You can't visualize that sort of the information. That is one of the limitations also that lead to an error. The navigation scheme or structure of the task, and that may affect your also performance of the procedure or sort of the management wise. These other things also here I mentioned, just to keep you in mind, it's difficult to review data that have been input into the system sometimes because system failure. We are depending on the system. Most of you are roaming around with iPad, roaming around with iPhone, and also in our hospitals there's MedTrack and there is a Shifa system where you put the information. Sometimes there's a crash of the system, so the information is not available for you. There be should be a background where this information is safe to help you. That's sort of mainly that sort of limitations I guess mentioned on human capabilities. To make it more interest for you before start into more theoretical part, I'll give you one case at least to let you think about what's happened on it accordingly. Here is we have a case of Miss Amna, which is 40 years old, was a fit and healthy young woman who came to the ENT department, and we admit her for routine ear surgery, and that procedure is done and patient taken to theater. During the anesthesia, she experienced breathing problems, and the anesthetist was unable to insert the tube, which is the device to secure her airway. And then after 10 minutes, it was a situation of cannot intubate, cannot ventilate. That's the anesthetist will cry that time, which is, we know it in our own setting in theater in emergency. For a further 15 minutes, 3 highly experienced consultants made numerous attempts to secure the airway by re-intubation, try to re-intubate, and so on. And that lead to several prolonged period of intubation and lead to dangerous level of oxygen in the bloodstream and low oxygenation. So that means hypoxia is being there. And then before the patient come, the nurse informed the team that there is already tracheostomy equipment is ready in the theater. And also a bed was booked for the patient in the intensive care. But 35 minutes after the start of the anesthetic, it was decided that Miss Amna should be allowed to wake up naturally. Even they attempt and they succeeded and they get hypoxia. After finishing the procedure, they decide after 35 minutes is that the patient will wake up naturally and was transferred to the recovery unit without thinking about the availability of the bed in intensive care or availability of the emergency equipment required at that time. So when she failed to wake up, she was then transferred to intensive care, which was late. If you say, suppose you have a beginning, can be transferred to that area, not to let awake naturally. Miss Amna never regained consciousness, and after 13 days, the decision was made to withdraw the ventilation support that was sustained her life. So the patient is died. If you look at this scenario, I don't know if you can write in chat what do you think it's happening. I'll be happy if you can share some thought before I give you my thoughts. of next slide. What about the superficial analysis and of this case? If you can write in the chat 1 or 2, I'll be very grateful. Otherwise, I'll continue, inshallah.
Feel free to write your opinion. There is no wrong or right answer.
Okay. So sorry. If you didn't able the, sorry, I thought only able to chat, but it seems to be blocked. So, thank you, Lubna. So now my the superficial assessment is here. Is a tragic is happened, as you may aware, but unavoidable event resulting from unexpected but recognized complication of anesthesia. However, the outcome could have been quite different. Because why I say this tragic but unavoidable, because sometimes difficult intubation may lead to hypoxia, but always there's some event happening. So if a member of the team here treating Miss Amna was experienced and technically highly competent with the consultants, so that at least there. But a detailed investigation highlights some of these factors. One is loss of situational awareness. They are in stress, under stress, they try to concentrate on repeated intubation. They can try to get the airway. As a result of this, they lost sight of bigger picture, which is the, we call it time passing and the severity of the situation, because that will result in hypoxia. And this is we call it tunnel vision, where they concentrate on something, but not in the bigger picture. And that is one of the loss of situational awareness because of stress. Perception and cognition actions were not in line with the emergency protocol, because of emergency protocol, if you fail intubation, you may think about something else, like tracheostomy. Try to open an airway there. So in the pressure of the moment, many options were being considered, but they were not necessarily the option that made the most sense of hindsight to this patient. Teamwork, there's no leader, no clear leader. All of them tried to get the secure the airway. Usually in emergency, you need a leader where he or she will give the orders and they know what's going on there. At least that follow of the leader is important, especially in CPR and the other same. So there's a leader and he can take decision, and maybe the communication between the consultant should be there. The culture here the hierarchy. The nurse, they know there's a bed in ICU. They know there's a tracheostomy set was in the room, but they didn't inform that time. They didn't want to disturb because of it's not utilized. Because of this sort of hierarchy of the team made sort of difficult, despite the severity of the situation, to speak loudly and to stop the process until there's something other options here for the patient, which can be used the tracheostomy or the intensive care. So that's in general the superficial analysis of this case, which I also as sort of introduction to our lecture today. If you can see the slide is, you need to keep it in your mind, is the setting the healthcare more dangerous than the road traffic accident or the airplane accidents. More than 1 in 1,000 at least affected per day in the healthcare, and that's around the world, and more than the driving accidents, and more than chemical explosion, more than the flight accidents. So that's sort of the number of encounter for each fatality is higher in healthcare compared to the others. That's the fatality. But sometimes 10% of any admission, 10% of any admission to healthcare setting may result into harm. Luckily, it's minor harm, either fall or maybe some drugs reaction, but majority of not happen like that here. But at least in healthcare, the more dangerous compared to the other things, and you keep in mind that's what happened in the healthcare setting. Therefore, the patient safety is important to be understandable, and also to take the precaution to improve the patient safety in the healthcare by understanding the sort of the what you mean by the error and what you mean by the others. Like this, your lecture, like sort of the awareness about the medical errors. In this definition, the error is a failure of a planned action to be completed as intended. This is what we call it error of execution, or the use of wrong plan to achieve an aim, which is an error of planning. That's two types of error we have. We have another terminology which is may happen in the healthcare setting. We call it adverse event, which is an injury caused by medical management rather than the underlying condition of the patient. What I mean by that is something happened to the patient during the admission due to the administration of the medications or medical management plan, and not due to his real condition. Yani the patient is admitted with uncontrolled diabetic, but he get a fall in the system. That sort of fall is not related to his diabetics, it's related to the patient safety within the organization. That's called adverse event. Also, could be that due to the drowsiness and there is no sort of measures where preventing fall in the hospitals led to this sort of adverse event, or another medication was administered to the patients and lead to the adverse event. So that's the definition of the adverse event if you compare it with the error. And we have this adverse event can be preventable, as I mentioned earlier, like a fall. You can prevent fall by raising the side of the bed, by developing the alert system in the hospital where the patient is moved or need to fall, there's an alarm, and so on. Some adverse event may lead to an error, and that's, we should keep it in mind also. And this slide shows you the relationship between the medical error and adverse event, and in between them, in this small area, is the preventable adverse event, which you can preventable, but the rest cannot be preventable. So therefore, the bigger picture here is maybe come from the adverse event. How common is the error? You may ask these questions. How it's common? Harvard Medical Practice Study, I know it's old, but it's showing between old and new shortly, reviewed medical chart of 30,121 patients admitted to 51 acute care hospitals in New York, and showed that 3.7 of adverse event led to prolonged admission. يعني مريض admitted with diabetic mellitus or complication of diabetic mellitus, but he fall down. That fall led to fracture. That prolonged his admission. Rather to be discharged shortly within maybe 5 days to 7 days, he stayed for 3 weeks to treat the fracture resulted from the fall. 69% of injuries were caused by errors. That's the study which is showed by Harvard Medical. The other one, the third leading cause of death in US, most doctors do not want you to know about it, which is the medical errors. A recent Johns Hopkins study claims more than 250,000 people in the US die every year from medical errors. Other report claims that number to be as higher as 440,000. Is maybe higher than that. 1 million may reach. Medical errors are the third leading cause of death after heart disease and cancer, if you imagine. And the first one, as I show you the slide, which is due to the accidents, is more in healthcare compared to the car accident or plane accident or the train accident. So they keep in mind this, which is, you will not be hesitate if you say that. Another Australian study where the investigation reviewed the medical records, the EBR or the chart of around 15,000 admission to 28 hospitals in New South Wales and South Australia in 1995, and this lead to they found 16.6% of admission resulting in permanent disability, and in 13.7 of patients, the adverse event in 16.6 led to permanent disability in 13.7 and death in 4.9. That's sort of the figure, which is really a big figure. 51 of adverse events were considered to have been preventable. Yani this sort of the adverse event can be prevented by doing the rules and regulations of patient safety. In Australia, medical error also result as many as 18,000 unnecessary deaths and more than 50,000 patients become disabled each year due to the medical error, either wrong site, wrong operations, or the administration of the wrong medications. These are the most common. In the United States, again, medical error result in at least 44,000, as I mentioned earlier, as many as, which is to unnecessary death each year, and 1 million excess injuries were in the United States. So this is some of the result of medical errors. If you can see the types of medical mistake causing preventable adverse event here, you will find that mainly performance of operation or procedure, which is 35%, and failure to take preventable measures in 22%. The rest unclassified or due to the system as a whole or to the medication errors or diagnosis error, 14%. But majority of this of medical error having to a failure, as I said, of performance of operations or procedure in the right way, 35%. In the coming two slides, I'm going to discuss with you types of error, which is about half of the adverse event occurring among inpatients result from surgery, as I mentioned already in the graph. Next come after the surgery, complication from drug treatment, therapeutic misshapes such as introducing wrong drugs, diagnosis error, and which may lead to operate on the wrong side or lead to operation, unnecessarily operations to a patient who no need for the surgery. So that's which is the type of errors. And two things can be cognitive errors such as incorrect diagnosis or choosing the wrong medications, more likely to have been also preventable and more likely to result in permanent disability than technical errors. This is along the, you can see this picture show you the delivery room and how everybody is there is working, either thinking about new babies or but unhealthy environments and so on. So that also gives you a picture of the things may lead to or breach patient safety. So which patients are most at risk of medical error? Those undergoing cardiothoracic surgery, vascular surgery, or neurosurgery because of the type of the surgery, because of either there is no enough experience or over treating or unrecognized signs in the post-op, and that lead to the most higher patient at risk. Those with complex condition, immunocompromised patients, diabetics, and those in the emergency room, because in the emergency room there's no same care, which is like the inward patient coming with road traffic accident or with other unrecognized condition, and that may lead to be at risk actually of the medical, because if you try to help with many things according due to the emergency situation. And also those looked after by inexperienced doctors and leave the intern alone in some area or leave a junior staff in an area to perform procedures, and older patients. So these are the patients who are at risk. You maybe ask me, why do errors happen? As I mentioned in the first slide, all humans make errors. Indeed, the ability to make mistakes allow human beings to function because we learn from mistakes. Humans, you intend to بالعربي احنا انسان جايه من كلمه نسيان مش علاقه نفهمها. Humans, all humans make an errors because of the ability to make mistake and learn from this mistake and then go around. Most of medicine is complex and uncertain because you have guidelines, you have regulations, you have standardized care being published by societies, but not, sometimes you may be faced by a disease or by a complex procedure which is not mentioned anywhere. We have uncertain, like what happened now during the COVID-19. There's uncertainty because it's a new corona to the society. It's may lead to maybe error and trial either in the medication use or the whatever use, that sort of the things. It may happen also and lead to medical error accordingly, or delay of diagnosis and expectation of complication because of new disease. until we study it. And nowadays, during the COVID-19, anything about the COVID-19 being published quickly, because at least people can learn from this experience and reduce the error. Most error results from also the system, inadequate training given to the staff. So they request from him to perform a procedure, but there's no training. Usually, we created now a structure of training for the new doctors who graduate from the medical school, is like Oman Medical Specialty Board, 5 years of training, supervised, under training, and then also this is now is adequate training is there, at least for some people who is there, but some people been placed in a place where there's no training, only they require his own help to be there, and also result in long hours duties, and that lead 4 hours because of the long hour duties lead to lack of concentration and also lack of sleep, and this depression deprive of sleep may lead to depression and lead to unconcentrations. Healthcare has not tried to make itself safe from beginning, because we need to have that guidelines and then make it safe. Maybe ours, I mean us as doctors, because we didn't care about our lives. Sometimes we go and work hardly and so on. There is no sort of the giving a chance for you to take holidays and so, especially in busy places. But now with the new regulations, with new training guidelines, at least the number of hours, number of also the cases can be determined through the training programs, and that will help to be trained yourself in the future to reduce the error. Even you as a medical students, you have some introduction on quality, patient safety, you have seen your colleagues work, they discuss the cases, they discuss mortality, morbidity, and then you can learn from this sort of errors accordingly. And how to think of error. We can think in two things, either individual or system. When you come for the diagnosis of what happened during the error or the root cause analysis, either individual cause or a system cause. System cause is the health organization or the health system, or so that system. They didn't provide you with adequate training, they didn't provide you with adequate equipment and so on. But for individual failure, here I'm listing 4 causes for that. Only the minority of cases amount from negligence or misconduct. So that's caused wrong diagnosis, due to the wrong diagnosis, because some training is not there. So maybe you lead to wrong diagnosis because no enough time to take the history, no enough time to do examination. You have 50 patients waiting for you to see. So sometimes you do a wrong diagnosis because you have quick need to finish your clinic, and then you have a load of patients waiting for you, and that leads to wrong diagnosis. Second, it will not solve the problem. It will probably, in fact, make it worse because it fails to address the problem. Because here, if you try to ignore individual things, ignore that sort of wrong diagnosis, and lead of yourself to work harder, and this may lead to depression and stress-related illness to the doctors. And doctors will try to hide errors in this case because there's no capability for the individual to sustain that errors. He is afraid or she is afraid from blaming and shaming. So maybe if he's working in a stressful environment, no blame, no shame environment, which is always blaming is there, then the doctors try to hide errors, and that individual failing. Also, if you've been faced by a victim, you'll be the second victim because you'll be also under stress and so on. So that's sort of the individual failing, is that error may lead to do this few things accordingly. System failure, this is the starting point from redesigning the system and reducing the error. Because if you think about the system as a whole, before starting a new departments or new service, you need to have a building, equipment ready, everything is ready, designing ready. You cannot start a service in a smaller room, which is supposed to be, you have a place for the bed, safety measures, exit doors, and so on. So that this is system failure, because sometimes during the investigation of the error, we may find the hospital or the system not providing the right equipment to be used by this physician to get the right diagnosis. So it's not always we put it in the individual as a cause, but also sometimes on system as a cause. But in Oman, when we think about the errors, we found it in the higher committee. They found statistics for the reason for the error for two things: either documentations, lack of documentation, or lack of the mainly the communication. So that the most common causes and error, I know there's individual errors and the system errors, but the majority in Oman during the investigation of the higher committee is either due to the lack of communication between you and the patient, and you go and complain because there's no communication what happened, there's no disclosure if something happened, that communications, and lack of documentation, you didn't document, so what happened? So that lead to be blamed. Usually how to respond by some tactics are there: reduce complexity of the system, optimize information processing by doing checklists and reminders and protocols. Unified protocols will reduce variability, because sometimes there's no protocols. Everybody will do haphazard, will work by its own brain, its own experience. But if there's protocol, understandable and unified, then you will be optimize information processing and automate wisely. When if I give autonomy to an area, should be by wisdom. There's enough budget, enough place, enough equipment to make it automated, and also use constraints, for instance, with needle connections, especially the needle stick injuries may happen in the hospital because there's no enough bag to keep the needles, or the wrong disposal of the needles. Maybe you kept it in the wrong things and kept it in black bags, and that will be injure people. Mitigate the unwanted side effects of change with training. For example, if you have some sort of change done within the organization, and then train them how they expect this change will be happening in the procedure wise or in the administration wise, and that will give you the right things to mitigate any side effects happen if change implemented. Because usually sometimes change is being forced on us, and that sort of force is not always right, because maybe there's no enough personnel to perform that change in that unit. There's no enough capabilities, there's no enough training, and usually management of change is by its own. It's what they call it, a study. Like in especially management change in healthcare is not, you should expect the unexpected, because sometimes we should expect something, but you may have some unexpected things happen in between. Therefore, be ready to respond to the change. And if you would like to plan for change for doctors or for nurses or for anybody, let them buy this change, involve them in designing this change, like feel the ownership, and that will if they feel the owner of that things will implement it, and that will reduce the error, reduce the whatever there, because if you involve people and feel they are owning the things because they are part of it, then they will work hardly and they will try to follow it up. But if something imposed, I had them this have done by them, not by me, so I not follow it. I have my own protocols, which is sometimes wrongly. Building safe healthcare system by this for the if there's some system errors, by putting principles, policies, procedures, practices in place, which is clear and announced to all physicians or employers in that organization, can be put in the system where everybody can see it in the computer, easy to get through, easy to get access to, and this unified process accordingly. Always, I'm just trying to give you the facts. Variability is part of the human conditions, falling off the system, we cannot change the human conditions. We can change the conditions under which people work. And it's a fact. Most of us will know it. Yeah, you can't change me, change the conditions under which people work, the circumstances, make it better for me to work, make it less hazardous for me to work, follow the protocols and so on. And that will reduce the errors accordingly. So always also the need to look on how to investigate and to find out what's going on there by, especially if the error happened. Maybe you heard about root cause analysis. You need to go back and look for the cause from the root. And then that's what you try to follow. You ask yourself why this happened, why this is happening, how this been happening. And then that's caused until you find the right cause for that. And that cause also, we have a tool called root cause analysis, which is a tool for identifying prevention strategies. It is a process that is part of the effort to build a culture of safety and move beyond the culture of blame. Because if you look into root cause and do a root cause analysis and look at the main cause for the problem, and then you can put a plan, an action plan to solve it, and then to make it as a lesson learned to you. And you can share this lesson learned with other colleagues, with other organizations, and then you can be also the fair for everybody. In root cause analysis, basic and contributing causes are discovered in a process similar to diagnosis of disease. Yani, go back and ask yourself why, then you can find something new, one cause, why this happened, that will go to another cause and so on. So that's called root cause analysis by looking in there. There are few steps in root cause analysis. Step number one, the most common element method variant, including asking, as I said earlier, in the why today's situation condition happened. While the answers are recorded, why it's happened, then ask why for each answer, again and again. Why? And then root cause analysis attempts to identify contributing factors and all causes possible by this way. This will allow you to proceed further by asking why until the desired goal of finding the root cause is reached. So that's the step number one in root cause analysis. Next step, to evaluate best method to change the root cause so we can improve our current conditions. That is another process commonly known as corrective and preventive action. Corrective, you correct what happened now, prevent the future one. While we are searching for the root cause, also we must remember to review each found cause and factor for correction as well, since this can also provide for great improvements because we can learn from it. So that's sort of the steps in root cause analysis. Do not answer in root cause what should have happened. Yani that blame. What did happen? What did not happen? And answer also what did happen? How did it happen? That's the root cause. What did happen and how did it happen? And be objective. Try not to use it as a blame and shame. Avoid that should be done, this not done, there's an error, there's a must, there's an inappropriate cause, and so on. So therefore, if you be healthy in the quality and you investigate, try to be positive. I know you maybe find some error there, but you can make it clear and do an action plan to prevent happening again. And if there's some blame and there's an error, of course there is accountability, because there will be accountability also if something made a mistake. It's not always there's no accountability. There's always a policy, there is a discovery of the error, and there's accountability, where people can be accounted for their errors if it's truly errors, either by warning, by if it's true error, or by other measures. But we are not encouraging putting the doctors in prison. But usually the court always here in Oman will ask the higher committee for it to investigate. And usually the higher committee will have experienced people around, and they can call for an expert from outside the field, and they can give their opinion accordingly. So this summary for root cause analysis, at least for you, the answer why it happened, compare with what should have happened, answer why it did not happen, do not answer how can I fix it, think of the environment as well, which is a system around you. Subjectivity is okay, apply different tools if necessary than root cause analysis. Root cause recommendation usually tie action to learning, as I said, because we need to learn from this error in the organization. Objective is to remove or correct root cause, must be practical, operational, and realistic. Always when you do say an action plan should be smart, should be easy to follow, that SMART method, which is subjective, measurable, approachable, and attainable, and you can put a recommendation on this, and timely framed too, because you need for any action a time to finish it. Choose best recommendation, and then be careful of consequences also, and check with the internal auditing system and the root cause analysis occurrence also, and if it's incidents also happening, then you need to find out why this happening again and again. So that's sort of root cause analysis. Remember to close the loop always. If you do a loop of the root cause analysis, close the loop. Measure, opportunity, study, intervene, and then improve. So you can close this sort of the cycle. And here is show you this sort of patient safety measure you can take. So number one, usually detect, then capture, classify the error, analyze it, then put priority, investigate, formulate, and then implement if an action plan required, then monitor this implementation, and then do again same cycle. But usually the document patient harm, then do a cause analysis and develop solutions. And if you look on this patient safety measures, always when you look on any errors happen. I know sometimes some of the errors are painful because may affect in the life of the patients, but usually always they need to look to learn from it, and also at the same time to prevent happening again. And if, as I said, if there is some sort of the recommendation for punishment and for accountability, always is there, and then with a simple way to understand it. This also summarizes the steps for the successful medical malpractice investigation or medical error investigation. Facts are gathered, number one. Two, evidence is preserved. If there's evidence, you take pictures, take the whatever that you can preserve it. Experts are found because you need some expert to give opinion. Maybe if there is an ENT, like a similar case I gave you now, there's an ENT involved and there's an ENT error, happen ear, nose, and throat error. I found an expert of the same caliber, senior person, to come and give his own expert opinion on the case. He will study the case and give to the higher committee that sort of opinion, if there's error, is there any negligence, or is there as malpractice, and so on. Usually you do witness testimony, is gathered information on potential, because that's some witness, including patients and relatives or the nurses staff. Then defendant is gathered. Also, if there's some sort of defendant, you heard from the witness, then you can get out. So these are the 5 steps also. I have attended the higher committee as expert personnel with them for some cases. So usually they follow these steps. They gather the fact first, they study the files, they study the case, and then get the evidence. If there's evidence been preserved, then they bring the expert, and then listen to the experts. If one expert is not enough, you can even this expert can be brought from other institution to become not unbiased, and then he can listen to them, and then also witness. As I said, they usually brought the patients, relatives, or any witness to listen to them, and then a defendant is gathered, and then at the end they'll vote for the decision making accordingly and get the results. Most of you have experienced simulation training or in skills lab or on lab or the things to learn some item, especially on delivery for boys. We have Victoria here downstairs in the medical skills lab. especially you can practice deliveries because not enough cases to be practiced in the hospitals. To reduce the error, the pilots been trained on simulation, how to drive the airplane, and that simulation will teach them how to drive. Then after simulation training, they'll go for to fly with the plane. And that simulation, we also in medicine we use it from this aircraft, because that aircraft simulations reduce the aircraft accidents and incidents and failure, which how many people's lives in that airplane, which has also been saved. If you can see now you are jumping in the airplane without thinking, because you know how safe it is. I know maybe something may happen in between due to some manufacturer, due to some things there, but it's less than what happened into road traffic accident or in healthcare. Therefore, some models of simulation was developed in medicine to help simulating the actual life in the hospitals and how to learn, at least to minimize the error, either for the new learned techniques or something a new knowledge to be also learned through the simulations. And also currently they do a simulating operating room facilities, that training of surgeons and of operating teams also at the same time. There's a simulation, full simulation OR, and there's people who will come there and do the actual life to learn how things going. Also recently there's some of the training usually on simulation, how to do some procedures, and this I was informed as instructor on silent endoscopy course in New Zealand that before my birth. So that's in along the years, but for few years accordingly. Currently, you heard about the robotic surgery. Also, the robotic where people are taken to be learn about robotic surgery, especially in urology or head and neck or in the other cases where robotic can be used and to improve the safety because the picture will be implemented in the robotics, and the robotics and the surgeon will sit here to only drive like in our days PlayStations. Now your days different techniques of things on that, and this robotic has been now a big center in Europe to train people how to do procedures in robotic, and then that improve patient safety accordingly. In conclusions, human beings will always make errors. Don't say people will not make errors because of nature of the human beings, the capacity of the memory, capacity of the how to understand, but always training knowledge will reduce the errors, and also providing the environment and the culture of working that will reduce the errors. Errors are common in medicine. Killing, as I saw you before, killing tens of thousands of people. We begin to know something about the epidemiology of error, but we need to know much more about the prevention of error. I kept it blank there for you to also say it. Prevention of errors. Naming, blaming, and shaming have no remedial value in medicine. We should learn from this error. If there's an error, we should disclose the error within the organization in a proper way, not in the street, where you need to explain to the patient if there's something happened, there's an apology, and there is a recommendation of something will not happen again by putting recommendation in place. We need to design healthcare system that puts safety first. First, do no harm. If you remember my ethics lecture to you, that's one of the principle of ethics is do no harm to the patients. And we know a lot about how to do that. But it's a long, never-ending job because we are still learning. Even now, I'm 28 years after graduation, I'm still learning. And that's you are learning every year about something new. And then even in social life, you are learning, and also environmental life, you are learning. In medicine, you are learning. But always there's a way to go around it. there is a way to save lives, and there's a really you can work around it and work like this picture there. He didn't want to cut the tree, and things he work around it to maintain the tree alive. That's also the humans beings. We should maintain and save the life of the human under any conditions, and that's the oath of us as we are always swear the oath either in your white coat ceremony, which I give it to you, and the oath, and or the oath during the internship. So that's the in summary and the introduction for the medical errors and how to go around it, how to investigate, and how to learn from it as opportunity of lesson learned. Now at the end of my lecture, I would like to thank you all and thank Lubna for the nice organization and for your society, Medsco. A lot of thanks for inviting me to be with you. And now if there's time for question, I'll be happy to answer it.
Thank you very much, Doctor, for this very interesting presentation. I think I speak of myself and everyone here that it was very informative. You covered many things. And like even the statistic that you brought up, even though they're shocking, but I think they do reflect the reality of medical errors and how common they are. And thank you for your presentation. Like generally, there are many people here in the chat thanking you for that. So as you, if you can stay here like for an extra 10 minutes for questions, if anyone has something.
It's my pleasure.
So all the participants feel free to ask any questions in the chat or maybe raise their hand if the media team will open the mic for them.
Anyone wants to speak, just raise hand, please.
Assalamu alaikum, Doctor. Thank you very much for your informative speech. It was really amazing attending and knowing about all these statics and new information. Now, my question is there any studies regarding the association between long hour training or the long time that medical practitioners stay at the hospitals and the medical errors, and what are the initiatives that are done to decrease such errors because of the long hour training or shifts?
Thank you for your nice question. Actually, yes, there is a lot of study been published recently linking the long hours of working with cognitive ability. As I mentioned, as ability of keep you awake, ability of thinking, and deprived from sleep, because if there's that long hours is also affecting, that lead to lack of sort of the memory, lack of concentration, and that lead to medical errors. Yes, there's a lot of study, but I didn't have it with me now, the statistics of how many, if the long hours is, as far as I know, as far as I have read, long hours drive you from sleep and they drive you from less concentration, and that lead to an error. So that studies are being around, and then maybe some extent were documented in some of the studies that around 1 to 3% of the cause of the error maybe due to the long hours associated with the long hours. What we have done here in the training system, like in Oman Medical Specialty Board, where there's a guidelines was put to reduce the on-call. During my days, we used to have, there is no much of regulations of duty hours. We used to do 3 days of on-call the whole weekend, like start from Thursday night until Sunday morning, continuous work. You are junior staff. Imagine that you have a few hours to go and sleep. Then you be drive and then you have an accident. There are some accidents reported due to the lack of sleep because of this long hours. They go home, but he'll nap in the car, and then maybe the accident happened. It was near to me where I was coming from the Royal during my internship. I was 3 nights near to have an accident close to my flat in Sib that time. And then luckily I stopped and then I slept 10 minutes and then I carry on to reach only to my home in Sib, from Royal Hospital Sib. What we have done now as follows. Number one is usually if the trainee or the intern have done 24 hours, usually next morning he'll go home after handover time. So he'll have no activities like to do to see new cases. So that's not more than 24 hours. Also, during the month, the on-call should not exceed between 6 calls, which is including the weekends, 6 to 7 calls per month maximum. And that is reduce the number of the tiredness, and because next morning they can go home. So that now we implemented in Oman Medical Specialty Board. If you are called 24 hours, we'll send you home after the ward round. You will not do any activities. You will not go to do a surgeries. Number 2 is the accreditation process of ACJMI, also doing monitoring now with us in the training programs in OMSP for the how many hours the residents be in duties per month, per day. And then that also been reported to the residents and reported to the trainee. And we try to minimize that. So yes, now the numbers of on-call is reduced. And even the shifts been also, if there's 12 hours call, there's some regulations there. If 24 hours call, there's some regulations there. But so becoming at least more regulated. And rather to spend 24 hours without sleep, and then you do another day of work, hand over and go home. And that's what currently we follow. Yes. And being governed by regulation of the international accreditation process for either SQ or for the other Minister of Hospitals. They follow the same currently for most of the staff. Unless there's shortage, but should be also given enough time for that. Even during the shortage, should be reasonable calls during the training programs. Did I answer you? Seems to be yes.
I think he's muted right now, but I think you answered very nicely.
Thank you.
You covered
There are 2 people raising hand at the same time.
so now we have Abdulrahman Jabri.
Thank you, Doctor, for this informative presentation. And if I can ask my question in Arabic to make it clear.
Please go ahead.
يعني دكتور
All of us speak
خاصة
Arabic,
نحن
All of us speak
طيب.
Arabic. Alhamdulillah. Go ahead.
نعم. In our society يعني هنا معنا يعني في المجتمع العماني تسمع سوالف، أي حد يخبرك سوالف عن المستشفى لازم يخبرك أغلبهن مشاكل، كله طبيب ما ياخذ البرا ولا، واغلبها يعني يتكلم عن الاخطاء الطبيه، وحتى شيء مستشفيات مشهوره بالاخطاء الطبيه، حتى يصير نكت من الايات المذكوره في بدايه مدخل المستشفى، كل نفس ذائقه الموت اول ما تدخل. ومنتشر هذا كثير. فاذا توضح لنا هل هذا تضخيم المجتمع او هو واقع، يعني هذه المستشفيات تكثر فيها الاخطاء الطبيه، وهل توجد احصاءات عدديه عن وفيات بسبب الاخطاء الطبيه في عمان؟ بارك الله فيك.
شكرا على سؤالك جيد. يعني ضحكت شوي على يضع آيات قرآنية أمام المستشفيات للأخطاء الطبية. هو طبعا كما تعلم في مضاعفات للعمليات أو مضاعفات للأمراض، وهذا معروفة، قد تؤدي إلى الوفاة أو قد تؤدي إلى أشياء ثانية. ومعظم الحالات التي تنتج في المستشفيات من خلال تواصلي مع الإخوان في لجنة الأخطاء الطبية العليا إنه مضاعفات للمرض، فقد تكون تضخيم من المجتمع فيه، لكن هذا لا يعني يمنع أن هناك حوادث نتيجة الأخطاء الطبية، لكن معظمها مضاعفات. أنتم قد تكون سمعتوا عن شخص ادعى أنه اكتشف حاجة قريبة في بطن امرأة وسوى عليها بروباغندا في الإذاعة والتلفزيون قريبا. يعني طبعا هي كانت لا تمس الموضوع الحقيقي في شيء أبدا، بينما هذاك الشخص اللي ادعى ذلك حاليا في التحقيق، واحنا في الجمعيه الطبيه العمانيه مواصلين مع التحقيق في هذا الشيء. قد تحدث اخطاء كما ذكرت، وموجود الاحصائيات للاخطاء الطبيه عند اللجنه العليا للاخطاء الطبيه، لكن المجتمع مضخم الرقم لاي مضاعفات تنتج اطلق عليها هو عباره عن خطا طبي. بينما الخطا الطبي معروف انه ينتج عن ميل براكتس او ينتج عن خطا نتيجه اجراء عمليه او فحص معين، نتيجه مضاعفات لخطا في الادويه او خطا في السيستم. هذا نوعين. لكن من نوع المضاعفات مثلا شخص وصل المستشفى في حاله ميؤوس منها نتيجه مضاعفات مرض معين، توفى في هذا المستشفى، فكثرت الحاله على المستشفيات معينه في السلطنه. قد تكون بعض المستشفيات في المحافظات، قد تكون ايضا في نفس الوقت مضاعفات المرض. لكن لا يمنع اذا احنا مثلا سمعنا عن شيء معين سواء كان من خلال الميديا ان نبحث فيه لماذا هذا حدث. وجدناه معظمهن 90 إلى 95% ما في أخطاء طبية. لكن طبعا موجود statistics، لكن لا يحضرني الآن. أنا طلبت من الدكتور وليد إنه يعطيني بعض statistics في الأخطاء الطبية وهو عنده، لكن ما تمكن يرسل لي بباوربوينت في خلال الفترة الماضية. العدد جدا ضئيل بالمقارنة مع ما هو يضخه المجتمع. قد تكون بعض المؤسسات الصحية كما ذكرت أنت مرتبط اسمها بهذا الشيء في المجتمع لأنهم ليست هناك ثقة. بينما الأحداث اللي تحدث في الهند وغيره، الأشخاص اللي يروحوا يتداووا في الهند أو يتداووا في تايلاند لهم أخطاء طبية كاملة احنا نراها لما المريض يرجع من هناك بأخطاء طبية عنده، لكن لا يذكرها أنها أخطاء طبية. احنا سوينا اللي علينا، دفع فلوس وما قصر كذا كذا. بينما هنا لعدم ثقته في الكادر الطبي الموجود هناك أو نتيجة حادثة معينة حدثت، أصبح يعني يطلق على هذا المستشفى ويطلق على الدكتور إنه هذا هو جزار، وهذا طبعا خطأ في هذا الموضوع. أنا أعطيكم مثال. في بداية افتتاح مستشفى السلطاني 1985، يمكن بعضكم غير مولود في ذيك الفترة. طبعا كان في فترة الافتتاح هذيك إنه بدوا يحولوا الحالات الميؤوس منها من المناطق أو على مشارف الموت ما يطلق عليه، فتصل إلى المستشفى السلطاني يا أن يموت في الطريق، يا يموت عند الطوارئ، يا يموت في داخل الحالة، لأنه وصل ميؤوس منه، ما يستقبل حالات جديدة. كان في البداية يستقبل محولين، وهم جزاهم الله خير في المناطق يحاولوا ما إلى آخر لحظة، فكان يرسلوا الحالة في آخر لحظة. فسمي في أول أشهر بمستشفى الموت، حتى أنه يعني ظهر توضيح من الوزارة ومن ثم حتى من مولانا في بعض المرحوم صاحب الجلالة السلطان قابوس في بعض اللقاءات الصحفية ذكر فيه. وحتى إحنا كدفعة أولى في كلية الطب لما دخلنا كان الناس يعني بروباغندا سووا علينا إنه هذا الطلبة سيتعلموا علينا، وإن هذا الطلبة يعني كيف يسووا العمليات، تعالوا ما تودوا أولادكم. أصبح يمتنعوا عن يجيبوا أولاده في المستشفيات حتى عن إحنا نقرأ عليهم العملية. إحنا كنا فقط طلبة نشوف مثل حالتكم حاليا أنتم، تشوفوا يا أسست يا تكتب يا تمشي وراهم بقرطاس وقلم. فهذا كنا انتشر علينا الخبر في ذيك الفترة. حتى مولانا نفس الشيء في لقاء صحفي في أثناء مجلس التعاون الخليجي في مسقط لما هو كان يسوي لقاء صحفي ذكر هذه النقطة، ذكرها أيضا حتى يطمن الناس بأنه طلبة كلية الطب عندهم سوبرفايزر، عندهم إنسان يعني خبير لا يقوم بلا إجراء العملية وحدهم، فاطمئنوا أن تروح على المستشفيات. فكان يعني يوصل طوارئ ويرجع، ما كنا نشوف حد لا نشوف ناس، نبغى نشوف ناس مرضى ما نقدر. طبعا في هذا الفكرة موجودة في المجتمع في التضخيم حاليا مع السوشيال ميديا، مع تويتر التضخيم عالي، لكن الأخطاء الطبية موجودة. لجان فرعية كونت في المناطق للنظر في الخطأ الطبي إذا كان موجود أو غير موجود، ثم اللجنة الرئيسية في مسقط في وزارة الصحة، ثم لجنة الأخطاء الطبية. لجنة الأخطاء الطبية العليا يرأسها دكتور من الجامعة محايدة، فيها جميع هذه أعضاء من مستشفى الجامعي، من مستشفى وزارة الصحة، من مستشفى القوات المسلحة، من مستشفى الشرطة. هذه تعتبر شبه محايدة، فالقضاء يلجأ إليها في الإكسبيرت أوبينيون، وهم في دورهم يقوموا بالتحليل بحيث ما يكون انفلونس تحت الوزير أو تحت كذا، لكنه على الأقل يعطوا رأيهم القانوني، رأيهم الإكسبيرت، بالإضافة لأنهم قد يسترشدوا بخبراء من داخل السلطنة أو خبراء من خارج السلطنة. لكن طبعا كلامك من ناحية تضخيم الناس موجود، الأخطاء توجد في مستشفيات فرعية أو رئيسية، لكن هناك إجراءات نقوم بها سواء كان في الجودة أو في سلامة المرضى أو الجايد لاينز. حتى منظمة الصحة العالمية تقوم بأيضا زيارة المستشفيات وإعطائهم بعض النصائح والإرشادات كيف تتصرف. فلذلك يعني طمن نفسك لما تجاوب انها قد يكون تضخيم، لكن الحدث الخطأ الطبي موجود لا محالة في كل مجتمع، كما شفتوا حتى في المجتمع اللي يعتبر مجتمع راقي من ناحية الخدمات الصحية اللي هو الولايات المتحدة الأمريكية، بريطانيا، الدول العظمى. ما بالك احنا في كدولة قد تكون احنا دولة يعتبرونها نامية، لكن احنا نعرف مقدار الموجود عندنا ومقدار التصرف فيه. لكن يعني إذا حدث شيء هناك ضوابط معينة موجودة من قبل الوزارة أو من قبل الجهات الرسمية لأخذ الحق للمريض يعني. وأعتذر طولت في الإجابة، بس أعطيتكم أمثلة من هنا وهنا على أساس أعتقد في رضا مسوي ريز هاند، ما أعرف لبنان.
ايوه دكتور،
أيوة
يعطيك العافيه دكتور على اول شيء يعني الجهد العالي في توصيل المعلومه والشرح يعني تجميع كل هذا الكم من المعلومات وايصاله بشكل جميل جدا يعني، وكلنا يعني نشكرك على هذا الجهد. وسؤالي فقط هو يعني فيما يمكن استطراد الى على سؤال الاخ عبد الرحمن، اعتقد انه في قبال هذا التضخيم من قبل المجتمع لابد تكون هناك خطط، حتى يعني تكون خطط مش مضادة لكن تواجه هذا التضخيم. يعني فهل مثلا وزارة الصحة أو أي القطاعات الصحية هنا في السلطنة يكون عندها خطط للتوعية؟ يعني الحين مثلا مثل هذه خلينا نقول الحضور اللي الحين كلهم موجودين، كلهم على مستوى التخصصات الصحية، لكن غير التخصصات الصحية الناس اللي من الفئات الثانية والمجالات الأخرى، يعني هي أعتقد الأولى بأن يعني تكون لها توعية أضخم من هذه الناحية. فهل هناك مثلا خطة لعمل ندوات ضخمة على مستوى المجتمع، على مستوى القنوات الرسمية، على مستوى كذا؟ يعني مثل هذه الأمور يعني ما ينتظرها خلينا نقول الطبيب أو الممارس في القطاع الصحي حتى تقع، ومن ثم شنو يبادر في دور التصدي والدفاع عن الخطأ، زين حتى مثلا بعدين يوضح شنو اللي حصل وشنو اللي ما حصل وشنو الإجراءات اللي راح تتخذ. فلما تكون بادرة أساسا من القطاعات الصحية والمجالات الصحية نفسها في خلينا نقول تضخيم هذا النوع من التوعية، زين، ويصبون كل الجهود في هذا المسار، يعني ألا يمكن يعني مثلا أنه يثمر هذا ويؤتي كله يعني بعد سنوات عديدة من التوعية، مثل ما حاصل مثلا في التوعية بشأن الفحص ما قبل الزواج مثلا. فهذا النوع من يعني التوعية هل هو موجود من ضمن خطط، يعني خلينا نقول إذا مثلا في قطاع ثقافي أو توعوي في الوزارات الصحية أو القطاعات الصحية بشكل عام؟ يعني هو هذا الجانب هل هو مأخوذ بشكل جاد أو فقط يعني خطط خلينا نقول رد الشبهات مثلا؟ يعني هو هذا سؤال أعتقد يمكن جريء، لكن ما جالسين نشوف بوادر، ولا بس يعني حتى على مستوى السلطنة، يعني كثير من دول الخليج أيضا قد يراعون هذا الجانب لكن ما نشوفه بذاك الثقل. أيوة شكرا دكتور.
شكرا رضا، سؤال جدا مهم وأيضا ملاحظات جدا مهمة. طبعا في الوقت الحاضر في محاولات، في خطط موجودة، لكنه في التثقيف الصحي حاليا معظم التثقيف الصحي قائم على البرايمري كير، على أساس الصحة للمجتمع، للقرية، للمدينة وما شابه ذلك. لكنه التوعية في مجال الأخطاء الطبية لسه ما محتاجة إلى جهود أكبر. حاليا في جهود تشكر عليها قام بها وزارة الصحة والجمعية الطبية العمانية، لكن أتوقع أيضا والجهات بعض الجهات الأخرى سأذكر أمثلة معينة حاليا، لكن محتاج إلى جهود أكبر. حتى أولا قد يكون نبدأ من المؤسسة ذاتها، من المستشفيات، كل مستشفى على حدة يقوم بعملية توعية من خلال معارض مقامة داخل المؤسسة الصحية. قد يكون في يوم في العام يقام معرض للتوعية عن الأخطاء الطبية داخل الوحدة الصحية ذاتها. هذا يعني كإنيشيتيف نبدأ من الوحدة الصحية في البداية، ثم إلى القطاع الصحي بشكل عام اللي هو مثلا الوزارة أيضا عندها خطط في مجال سلامة المرضى وجودة. حاليا التوعية الصحية قائمة فقط في أثناء بعض المناسبات. أنا يعني قد يكون محتاج في بعض المناسبات اللي هي أجريت تم عقد ندوات في ندوة الأخطاء الطبية في معهد القضاء العالي في نزوة قبل حوالي 4 سنوات. طبعا هذا مقل، كل 4 سنوات أو 5 سنوات تم عقد هذه الندوة في توضيح الرأي الطبي، الرأي القانوني، وأيضا الرأي المجتمعي في الأخطاء الطبية، وذكروا بعض الأمثلة وتمت نقاشها في ندوة يوم كامل حضرها عدة مسؤولين من سواء كان من الناحية الدينية أو من الناحية العلمية أو من الناحية القضائية. فتم النقاش ورفعت توصيات معينة بحيث على الأقل ترفع للمستوى الأعلى في لما تجي مسألة المقاضاة. فهذا طبعا ما وصل للمجتمع كمجتمع إلا يعني وصل إلى ما هو بعد المجتمع. طبعا شارك فيه جزء من المجتمع من خلال حضور الندوة. في ندوة أخرى أجريت قبل سنتين قبل كوفيد 19 في 2019، ندوة أخرى أيضا عن الأخطاء الطبية ودور المؤسسات الصحية والمجتمع فيها، عقدت في مركز عمان للمؤتمرات من ضمن مؤتمر المستشفى السلطاني. قامت بهذا الدور في عقده، أيضا عبارة عن حضروا حوالي 500 شخص في ذاك اليوم للتوعية بهذا الشيء، نقلوا التلفزيون، نقلوا الأخبار كذا، فقد يصل إلى المجتمع. لكن لسه إحنا نحتاج كما تفضلت ذكرت إلى توعية أكبر. في الآونة الأخيرة الجمعية الطبية العمانية قامت بالرد، وهذا فقط قائم بالرد كما تفضلت ذكرت، عبارة عن في فعل وفي رد فعل. يعني في حاجة حدثت أنا أتكلم، ما حدثت أنا ساكت، لكن في خطة موجودة طبعا، لكن قد تكون مفعلة باتجاه معين لحماية حماية المؤسسات الصحية والأطباء والعاملين الصحيين، بحيث على الأقل ما يرموا للسجن مثل بعض الدول بهذه بدون سبب معين. لذلك حتى كان في بداية الأيام إن الطبيب يعني لما يسأل يخلوه في قفص الاتهام، كان في المحكمة داخل البرزن، هذا في السجن في المحكمة، فتم اعتراض على هذا الشيء، والحمد لله تمت الموافقة إنه الطبيب مهما كان السؤال فيه ما يقص في القفص الطبي، ما يبدأ يعني يجاب كأنه متهم في القفص الطبي، يبدأ يجلس في مكان معين أمام القاضي ويبدي برأيه. فشوية فهذه شوية كانت ببعض المساءلة اللي فيها عن طريق الادعاء العام أو عن طريق كذا. طبعا يحتاج في الوقت القادم من الجمعية الطبية العمانية ومن المؤسسات الصحية الأخرى والمجتمعية أن تقوم بالتوعية المجتمعية عن التفريق ما بين الخطأ الطبي وما بين المضاعفات، لأن إحنا كعاملين صحيين نعرف الفرق ما بين المضاعفات وما بين medical errors، لكن محتاجين إلى كذا. لكن هو بسبب حساسية الموضوع معظم الدول كما تفضلت الخليج وغيره، حتى الدول العربية بشكل عام ما يعني تقوم بالدور المطلوب فيه المجتمعي للتوعية. معظم الدول العربية، معظم الخليج. الدول الأوروبية قد تقوم بالتوعية من خلال المؤسسات الصحية ذاتها. في بريطانيا مثلا NHS تقوم بالتوعية من خلال المؤسسات. في آخر وزير للصحة في بريطانيا يعني التقيت به في عدة مرات في مؤتمرات البيشن سيفتي، ومعنا حاليا في بعض اللجان في منظمة الصحة العالمية. شاف مستشفى معين تكتب فيه الأخطاء، يجي ريبورت ما عارف السبب ايش، ناس في موتى كثير. فاخذ على عاتقه هو كمسؤول انه يروح يزور المستشفى، يعرف ايش صاير بنفسه، ويعرف وسوى انفستيجيشنز وسوى، وجد انه قد تكون من اشياء جدا بسيطه اللي هي يعني نتيجه عدم توفر الاكسجين الكافي، عدم توفر بعض الاشياء ما تؤدي الى الوفاه. فلمنعه ادى باصدار قانون من مجلس العموم لفرض بعض اخذ من ميزانيه الدوله ورفع ميزانيه وزاره NHS حتى تعوض هذا النقص، ومع المونيتورنج قللت الاخطاء الطبيه واصبح هذاك المستشفى الناس تقصده بدل ما كانت تهرب عنده. كما ذكر الاخ عبد الرحمن ان بعض المستشفيات عندنا يعني ليبل باي ايه قرانيه، بالايه القرانيه. فهو لا، يعني يجب ان ناخذ المسؤوليه على عاتقنا. فهو قد يكون ان شاء الله تعالى بجهودكم انتم في المستقبل تكثر التوعيه، تكثر هذه المجتمعيه، لكن نعم يحتاج الى مزيد من العمل. لكن في جهات قائمه بدورها بما فيها وزاره الصحه والجهات الاخرى والجمعيات الخيريه. اوافق رايي في بعض الاشياء يعني. شكرا اخي رضا.
شكرا دكتور، وشكرا رضا عبد الرحمن وطارق على أسئلتكم، كانت أسئلة حلوة والدكتور جاوب عليها ويعني كفى ووفى. So thank you everyone for attending today. I'm just gonna mention one question. This will be the last question that was raised in the chat.
دي اللي بدنا اشوفك رافع ايدك يعني.
عشان البنت اللي كاتبة في الشات. Okay, so if the doctor makes a mistake, should the patient always be informed? يعني just briefly, do we have to tell them?
إذا جينا إلى الحقيقة يجب أن يخبر، يعني مهما احنا نسميها يعني يخبر بطريقة طبعا علمية مهنية، تسمى عندنا disclosure. If event happen, disclosure should be planned. بمعنى إنه يكون في area sitting within the organization، في غرفة ما في كوريدور، يكون المريض والريلاتيفز والطبيب وواحد ادمنستريتور موجود، يشرح له انه في شيء حدث عندنا، حدث شيء الفلاني كذا كذا. طبعا يعني يوصل علينا في شيء حدث، اذا كان في شيء حدث يمكن يقول يعطيه الابولوجي. لذلك اولا اكسبلانيشن، خذي كاي ان تي انا اير مشان ديسكلوجر، اير اي فور اكسبلانيشن، اكسبلين وات هابن، اشرح الحدث. شوف اللي حواليك المضاعفات او في خطا معين حدث، ثم بعدين ممكن تقول we are sorry this happened، لكن احنا we are in action to do a recommendation to prevent it not happen again. في بعض الحالات هذه طبعا في حالات معينه لكل complications معين، بس في حساسيه معينه لو في خطا كبير حدث، في حساسيه ذيك اللحظه تخبر المريض، لكن ممكن تخبره عن بطريقه غير مباشره بوجود المسؤول الاداري، بوجود العائله، بوجود كذا. انت ما تبغى واحد يكون يمسك مرقبتك يبغى يقتلك ذيك اللحظه، انت خلاص. في شيء معين انك ممكن تحدث تعطيه اولويات، لكنه في تخبر مدير عام مستشفى طبعا، تخبر كل حد في البدايه، بعدين تاخذ رايهم متى الوقت المناسب احنا نختار المريض. ما تخبها انت، يعني ممكن تسوي بلان للخطا الكبير. انا اتكلم عن في مضاعفات بسيطه تحدث، عشان كذا نسميها ديسكلوجر، يو ديسكلوز. هذا معروف في الهيلث كير. explain apology and recommendation what to prevent not happen again. لكن في خطا كبير حدث لابد انه المدير العام المسؤول المباشر للمستشفى، الجهه الرئيس القسم قبل الاشياء، ثم يجلس مع بعض متى الوقت المناسب لاختار المريض. قد يكون اختار في تلك اللحظه او في بعد ذلك، او التأني في الموضوع حتى ما يسمى التحقيق يخلص، بحيث يعني ما تروح ترمل المريض كذا وبعدين ما يكون عندك الحين القدرة على الرد. فهي في حالات اللي هي ممكن ما كبيرة جدا، نعم الكبيرة جدا نتأنى فيها قبل فأخذ رأي المدير المسؤول، لكن ما نخبيها، ثم نعمل لجنة تحقيق، ينتهي التحقيق ثم نجيب المريض نخبره ايش حدث. هذا المفهوم. والمريض بامكانه يعمل كومبلين اذا لا سمح الله ما حد خبره، يعمل كومبلين للمدير مباشره، او عن طريق خدمات المرضى، او عن طريق في ناس يروح كومبلين للدعاء العام او وزاره الصحه، فيكونوا لجان جديده. لكنه من حق المريض ان يعرف ماذا حدث. لكن كما خبرتك في احداث الكبيره الميجر يجب التأني فيها، يجب اخذ فيها الراي المسؤولين، ثم وضع لجنه تحقيق النتائج، ثم بعد ذلك المريض يجاب ويخبر بعد انتهاء النتائج. ما يخبر ذلك الطبيب المعالج بنفسه، يخبر رئيس لجنه التحقيق ووجود المدير العام.
اللي هو في يعني كما تقول إجراءات معينة حالي وبعد لكل حدث حديث يعني.
بالضبط، اي نعم، لكنه من حقه المريض ان يعرف ايش حدث. فهذا معروف في اي ديسكلوجر، اي فند معروف عندنا في الهيلث كير يسموها ديسكلوجر. You disclose to the patient what happened. هذا في الإثكس معنا.
شكرا مرة ثانية دكتور على إجابتك. بنهي الحين بقول إنه عارف إنكم واقف أسئلة واستفسارات وموضوع الأخطاء الطبية، ولا بتكلم إنجليش؟ ما في أحد هنا ما يفهم عربي. بس generally medical errors topic is a very, very broad topic and it has like many raised questions. Just so you know, and we still have 2 other team events. Tomorrow we're going to be having a lawyer. That's part of the higher medical committee. We're also going to be having Dr. Abdullah Al-Asmi, the chairman of the higher medical committee too. So inshallah, they're going to be able to answer like your questions that you have. And then by the 3rd day, we're going to have also a psychiatrist that's going to be talking about the psychological impacts that doctors face after like committing a medical error. So stay tuned like for the other topics and our next presentations. For now, I'm going to be closing by asking you all, if you're comfortable with this, open your cameras, please, and let us take a photo for the future. Okay. We'll give you like a minute إذا حد يريد يعني يرتب شكله وشكل. You have a minute. Meanwhile, I'll just thank you one last time, because for those who doesn't know Prof. Rashid Al-Abri, he's like a very, very great surgeon and a doctor that's part of different committees. He's an active doctor and we should all look up to him one day. I personally do. So thank you for accepting our invitation.
Thank you all really for the listening, bearing with me with my also the long talk. So thank you for the understanding, and I'm happy that you'll be having another session tomorrow, and this will be enlightening from the higher committee, which is the main committee here in Oman for medical errors. Thank you. And then one request, you guys, can you send me a copy of my the picture you took, the photos? I'll be very grateful to you. I can put it on my Twitter.
Okay.
So thank you. Thank you.
I'll send it to your email after the meeting.
Thank you. Thank you.
So I think we're gonna take it now. I'm gonna count to 3. Smile, everyone. 1, 2, 3. Looking great, everyone. Thank you for attending. I'll be sending the photos to you now, right away.
Thank you.
I think by now we're gonna end the meeting. Just a quick reminder, we have, after half an hour, a standing committee session, so don't miss it. Bye.
Bye.
نطلع نحن OC ولا أصلا I have to press it.